Hi everybody, this is Jacob Kirsch, President of North American Society for Cardiovascular Imaging. Thank you all for joining us. We have a group of people already online and they continue to log in. It's 4 o'clock, so we'll just start setting this up while others start to log in. So today we can stop this. We had a few really good cases, courtesy of Dr. Diana Litmanovich from Boston. Diana is actually held up with clinical work that she had to kind of last minute go and attend to, but she sent me her slide deck presentation, so we're going to go through them. There's a lot of cases, so we may not get through the entire presentation. I have some other cases to present, and I believe some of you guys may want to present cases as well. So again, this is cases from Diana, and I have not seen them, so I'm going to be taking them blindly. Feel free to comment since we have a relatively small group today. Everybody's busy dealing in their own institutions with the pandemic, but I see some friendly names on the list, so feel free to comment as we go. Remember, this is an educational experience for all of us. This is about sharing cases as we go. All right, here we go. So case number one. All right, these are nice images. So we have a 40-year-old man with intermittent fevers, substernal chest pain, and leukocytosis. The next step, we need to determine what's the next step in management. So why don't we just describe these images as we go. We have two CT images followed by an MR image. So this in the axial plane, we're at the level of the sinus valsalva. We see the right coronary artery coming out here, and we see here about the anterior heart and right heart wall. We see some pericardial effusion. The pericardium seems a bit thickened and probably enhancing a bit. It's relatively bright, so I would suggest there's some enhancement of the pericardium, some loculation of the fluid. We see that it doesn't go all the way around the pericardial space, and it actually kind of curves here. So some thickening, enhancement of the pericardium, and some fluid, mostly to the right and anterior to the heart. This is a coronal. This looks like a MIP, like a maximum intensity projection. You can tell that it's a little bit hazy, some of the images, and that kind of clues me into this maybe a MIP. And again, to the right of the heart, we see disloculated pericardial effusion with pericardial mild thickening and enhancement. We use 4 millimeters clinically to determine if the pericardium is thickened or not. But again, that is just a number, and you know that nothing more dangerous than a radiologist with a ruler. And this is a late enhancement phase-sensitive inversion recovery image, axial through the heart, and shows all of this darkness here. That's the fluid. Of course, I won't take up the contrast, but look how thick and hyper-enhancing both layers of the pericardium are. So this looks like a pretty good case for an acute pericarditis. The amount of fluid is probably moderate to severe. It's probably more than 1 centimeter. That would be considered severe in the echo literature. And I'm not sure, but it seems to be putting a bit of an impression here on the right atrium. Not so much on the right ventricle, but at least some here. So there may be some constriction to go with it. So let's see what Dr. Litmanovich says on her slide. So an unevenly distributed pericardial fluid and late gadolinium enhancement. There you go. We talked about this. So what's the best next step? Anybody out there wants to pick one of this? Don't be shy. Anticoagulation, send to cardiac cath. Yes, run to the OR to repair the ascending aorta that look normal, or a pericardiocentesis. So not necessarily my favorite answer altogether, but I think out of the four, definitely the last one is the one that would fit the clinical picture. So pericardiocentesis is a treatment for acute pericarditis complicated by pericardial effusion and tamponade physiology. So I'm assuming that looking at more images and supported by evidence, clinical evidence and echo evidence, there was constrictive pathophysiology associated with how those right-sided chambers and the interventricular septum were moving. So suggestive of tamponade on top of the acute pericarditis, and that would help pick the pericardiocentesis answer in this case. So a couple teaching points. She did a great job with these slides, by the way. So we have a low density pericardial effusion, enhancement of the layers, leukocytosis, chest pain. I guess here it should read acute pericarditis. And when we see mass effect on the right heart and finding suggestive of heart failure, either clinically or by imaging, we should at least suggest the possibility of constrictive pathophysiology associated with the pericardium. So echo, modality of choice for assessment of the pericardial effusion. And we know that CT and MR, we see these patients when they want to see if it's loculated, if they want to look for secondary findings as well, of pericardial thickening, etc., to suggest a potential etiology to the effusion. So this is a nice case. You see here the pericardial effusion, pretty high in attenuation coefficient, suggestive of maybe blood byproducts or a more proteinaceous, sorry about that, a more proteinaceous component to the effusion, and your differential diagnosis then becomes if there's an underlying malignancy and it's a malignant effusion, hemopericardium, this is a purulent exudate. Hyperthyroidism is, they usually are very large, those pericardial effusions. In my experience, they don't necessarily have to be high in attenuation, not that you see them that often, but when you see them, they are very, very big. I've seen a couple and they are not high attenuation, but they are definitely on the larger side. And of course, a hemorrhagic effusion will have some effect on the magnetic environment under MRI and give you an increased T1 signal intensity and spin echo. Like we said, over 4 millimeter by imaging, we start considering that abnormal. Now, patient with less than 4 millimeters can still be abnormal, and that's going to be a clinical diagnosis on top of the imaging findings as well. Enhanced thickened pericardium indicates inflammation as well. Here's a very classic view. You see the contrast going into the right-sided chambers of the heart, and there's significant regurgitation into the suprahepatic inferior vena cava and to the hepatic veins. So that means that there's increased pressures in your right-sided chambers, and that may be suggestive of constriction in the appropriate clinical setting. I mean, you can also see it in other cases such as congestive heart failure, or even when you're injecting contrast large amounts of bolus very quickly, just by how the SVC kind of points downwards. You can have a bit of a reflux into the IVC depending on the bolus of contrast you're giving in an otherwise normal cardiac structure. You here see that there's flattening during inspiration. This is suggestive of the interventricular dependence, and that's also seen in constrictive pericarditis. That's a pretty classic. That's why we do also some free breathing MRI in these patients to be able to see how that septum will change during inspiration and expiration. So some mimickers of acute pericarditis, epicardial fat necrosis, not very common, but we do see it. So when you have patients coming through the ED with this acute chest pain, pay attention to the epicardial fat planes around the heart. You can see some stranding, and that may be very, very suggestive of acute pericarditis, fat necrosis, which mimics acute pericarditis. Really nothing to do about these patients. It's a diagnosis of exclusion unless you have a case that's extremely obvious. Like this one is usually much more subtle, so it becomes some sort of diagnosis of exclusion. Clinically, some patients get worsening of symptoms when they lean forward with this, which may also be the case for acute pericarditis, so not that helpful, I guess. So some treatment for acute pericarditis, when it is uncomplicated, basically just some supportive therapy helps, and colchicine can help with the inflammation in these patients. Refractory cases may require the use of steroid. Again, if you have tamponade physiology and constrictive pathophysiology, pericardiocentesis is going to be indicated. And eventually, if you have chronic constrictive pericarditis, a surgical repair or by pericardiectomy should be considered. All right, so Dr. Lidmanovich did a great case in walking us through that first case. Let's look at case number 2. Welcome, Madam President Ordovas. We're showing cases of Dr. Lidmanovich who couldn't join us, so feel free to chip in as we go. So we have a 56-year-old man with progressive shortness of breath over a period of 3 months. So on the left, we have 2 axial slides through the aortic arch and a bit lower, close to the sinus of Valsalva. I believe we see here the left main coming off the left sinus, so further down. And then here we have a sagittal oblique multiplanar reconstruction, almost a candy cane showing most of the aorta. So let's go over the findings. We have this what looks almost like an infiltrative soft tissue process, both sides of the arch and by the aortopulmonary window here. So also below the arch, as we can see here on the second axial image, kind of splaying, putting some pressure in the left atrium and maybe even splaying a little bit the pulmonary veins, which we kind of see there. So we see an obliterated transverse sinus and infiltration of the pericardial recess. This is following pericardial boundaries. So yes, we see the transverse sinus. We see here also the oblique sinus behind the heart. So it's following the pericardial boundaries. I'm assuming Dr. Lidmanovich is trying to tell us that the origin of this may be related to the pericardium. Let's see. Yeah, between the aorta and pulmonary arteries, like we said earlier. So differential diagnosis, hemopericardium, lymphoma, metastasis, pericardial cyst, and a primary pericardial synovial sarcoma. Anybody wants to give an opinion? I don't know the answer to this. Go ahead.
Lymphoma, maybe?
I'm sorry?
Could be. I am between lymphoma and pericardial synovial sarcoma.
Yeah, I would agree with you. Definitely, it seems to be somewhat infiltrated, but without really infiltrating the tissues, but just the pericardial spaces. Lymphoma tends to do that quite a bit. It's definitely, I doubt it's a hemopericardium. If it was metastasis, I would hope they would give us a history of a primary tumor and does not look like a pericardial cyst. It's too high in density. So those are very, very good options, lymphoma and primary pericardial synovial sarcoma, both of which are actually pretty rare. Let's see, we're going to start with the differential diagnosis. Oh, sneaky Dr. Lidmanovich. So this is CTA, shows a dissection. Here we see actually the dissection flap on both the ascending and descending aorta. We see contrast extravasation. Here, the black arrow is shown to us medial to the ascending aorta. And then this hyperattenuating fluid with potential mass effect, which is tamponade. Lymphoma, here we have a case images, so we see heterogeneity to the spleen and infiltrating here in the heart. This is definitely infiltrating the soft tissues and the pericardium. Again, has that soft tissue appearance like lymphoma does. It just kind of grows around most of the structures. is also relatively common in the right AV groove to see, which doesn't help us because that's also where angiosarcomas like to grow. All right, so that's encasing the RCA and associated pericardial effusion. That was a lymphoma. So low intensity pericardial mass, we know that because of the nuclear to cytoplasm ratio of the lymphoma cells usually, the right atrium and ventricle invasion and associated pericardial effusion. So again, there's some invasion. It doesn't look always exactly like an angiosarc, but when seeing a case de novo, I think if you bet on angiosarcomas, that's probably a better bet because of them being a lot more common than primary cardiac lymphoma. If the patient has a history of lymphoma somewhere else, then that's a different story. Being a primary cardiac tumor, then you would bet on angiosarcoma usually most of the time. Pericardial cysts, again, most common in the right cardiophrenic angle. Then the second most common place is the left cardiophrenic angle. They're really somewhat rare anywhere else. Although we do see them because they're common all in all. Those are by far the two more common sites. Fluid density, which didn't fit the case we saw, rounded, well demarcated, and no mass effect. This can also change if the patient, to change the patient in position, they can change how they appear. So it's sometimes helpful to put the patient in the prone position if you're having questions about what the diagnosis may be. And pericardial synovial sarcoma, large soft tissue pericardial mass, invasive and significant mass effect. Look at this, is enhancing heterogeneous and can be multilocular pericardial mass. I have seen this before once. I don't recall it being multilocular like this one seems to have different cavitations within it. Common to have invasion into the right atrium and IVC. Like we needed an arrow to see this, right? There you go. So this was a case of primary pericardial synovial sarcoma. Again, pericardial involvement by Mets are more common. The spread can be hematogenous or lymphatic. This is for Mets in general. And again, the most common malignancies to metastasize are breast, lung, lymphoma, and melanoma. But of course, these are also extremely common neoplasms to start with. So that's why we see that incidence to be so high as well. When it comes just to, when we normalize for incidence of cancer, melanoma, it's the one that metastasizes to the heart most often. Some autopsy literature talks about 50% of patients may have some at least micro involvement in the myocardium. CT and MR, pericardial effusions thickening, irregular pericardium, pericardial mass effect, and strong enhancement. We're talking about metastases, I'm assuming here. Most common of the pericardial neoplasms in general. Melanoma may have increased T1 signal because of the melanin. This is actually hard to really identify in real life, but if you see it, that makes it easier for you. The primary malignant tumors of the pericardium are very rare, and those are going to be mesothelioma, lymphoma, synovial sarcoma, and liposarc. But again, these are primary tumors are relatively rare. So what are teaching points? No non-primary tumor, surgical biopsy may be required, and treatment is palliative chemo or radiation. These patients have a very dismal prognosis. These are very hard to treat cases, especially when they have infiltration into the myocardium, like lymphoma. In general, lymphoma responds well to therapy, correct? The problem that we run into is when they're infiltrating the myocardium is that they can respond so well and start to shrink, and there's maybe a little myocardium left in place of the lymphoma that the patients may actually then weaken their myocardium and rupture, and then die of pericardial tamponade and myocardial rupture during therapy. So even those patients that in theory should be relatively responsive to therapy, like lymphoma, the therapy has to be done very, very carefully with very small doses to try and preserve that integrity of the myocardium. Okay. Any comments on that one, doctors? All right.
Impressive case. That was really good.
Yeah, well, I didn't put it together. That was Dr. Limanovich. So yes, she did a great job. All right. Case 3. 42-year-old previously healthy woman with chest pain on exercise. So we have 3 axial slides on a ECG-gated study, looks like. It's walking us, I think, near the area of the sinus of valsalva, and the first thing that kind of catches, there's 2 things that catches my attention. The first one is I don't see any vessel coming off the left, and then we have this vessel in front of the right ventricular outflow tract. If you were here for the 2 webinars ago, the first webinar we did back in February, we showed a bunch of cases, a cluster of cases of variations of this, I believe. Let's see. Yep.
Anomalous LAD.
I'm sorry?
I'm sorry.
Oh. Okay.
Anomalous LAD from right?
Yeah, that's exactly what it looks like. Very good. So here we have an oblique coronal view trying to show us the right sinus of valsalva. So this is the LVOT here. So we see part of the mitral valve. This is going to be right atrium. Patient seems to have either a pacer or an AICD here, but we see the right coronary artery going down. We're expected some plaque in it next to the AV groove, but then we have this additional vessel that tracks along and towards the interventricular groove between the left and right groove. Here we see it also on this volume rendered image and follows that LAD distribution. So I would agree with you. Abnormal vessel, expect the location of the LAD. So same images, but now with yellow arrows to show us the finding. So this is an abnormal vessel. It's an abnormality of origin. So you can have abnormality of origin, you can have abnormalities of course, and then you can have also abnormalities of connections and terminations. If there's usually when they fistulize, for example, into the chambers or such, or an extracardiac structure. So the origin of this LAD-like structure is the right cusp, so that's anomalous, and then it goes anterior to the pulmonary artery and terminates where the LAD shoots. This is an anomaly of origin. There you go, your VRT. This is one of the less common coronary anomalies, those that got LADs that go in a pre-pulmonic course. Those are very, very rare. So here we have the differential, but I think we know where we're looking at. But these are actually good differentials that for discussion of anatomy. So is it a conus branch of the right coronary artery? Is it an interarterial left anterior descending coronary artery? A prepulmonic left anterior descending coronary artery, or a transeptal left main? Okay, so we already discussed this. We know this looks like or we think it looks like a prepulmonic left anterior descending coronary artery. Again, common origin with the right coronary, or at least adjacent to it. And then it continues anterior and to the left. So let's talk about what the conus branch. So the conus branch is usually the first branches from the right coronary, and sometimes the left coronary still has a remnant of a small conus branch. Again, these are pretty much embryological remnants. They're a little bit more prominent in some patients than in others, and they can serve as collateral flow in cases of severe atherosclerotic plaque that has flow limiting effects. So they can help to collateralize flow through them for sure, or in other congenital abnormalities. So there's a right and a left conus branch. When they meet each other, like in this VRT here on the right, this has been called the arch of Vuesens or the artery of Vuesens. And again, it may help when there is a proximal occlusion of the right or the left coronary arteries. It's like a embryological bypass. It engorges it and allows for some collateral flow. All right, so we're going to learn embryology. So this is the interarterial course, which is not what we're seeing. So what we're seeing is anterior to the pulmonary artery. Here is when it goes, again, from the right, but it goes between the two arteries, the pulmonary artery and the aorta. That's why it's called the interarterial course. Here we see an example of that. We see the left main is coming from the right. Here's the right coronary artery, so it's traversing in between the aorta and the right ventricular outflow tract or proximal main pulmonary artery. So there it is, that anomalous course between the two arteries, the interarterial. This can be associated with an increased risk of sudden cardiac death. One of the reasons that they think that this may be the case is the pressure between the two arteries, which are high pressure structures, may actually narrow and give you this slit-like appearance to the coronary. So that may be one of the reasons. Also, as it gets near the origin, that slit-like appearance allows for that wall, the inner wall of the vessel that forms part of the aortic wall, it becomes a one-way valve. So when the pressure increases in the aorta, it becomes a valve. It kind of uses that as a flap to close off the origin of the coronary, and that may also be part of the situation here that leads to sudden cardiac death. There's a lot of controversy. People argue about this because coronary flow is diastolic, not systolic. But again, it's just one of the theories out there. And here's another one of those diagrams just to show what a prepulmonic course would look like versus the normal anatomy, and that's the case that we are seeing today. So this is another gated CTA, the LAD crossing anterior to the pulmonary artery with several areas of narrowing in the LAD. Again, very similar. It's not the exact same case that we saw. It's another example. It's a companion case, and again, similar findings. Patient which looks like severe disease on that right coronary, but a lot of what we're looking at may just be pulsation artifact, some motion artifact on that right coronary in these images. Okay. Now the transeptal course is when the artery goes through the wall, or I should say through the septum, through the muscle between the two arteries, and that has been theorized has a protective effect on the coronary from what we discussed earlier, that pressure from the aorta and the pulmonary artery. And you can see here, these are maximum intensity projections. So this is a thick slab. You can see that it's going between the muscle. Here is between the muscle. So it's not floating between the two vessels. So that has been, again, associated with improvement in the chances of sudden cardiac death compared to the interarterial course. So that's the diagnosis. Some teaching points. So we can have abnormalities of origin, abnormalities of course, and abnormalities of termination, like we talked about. Those are those that are fistulizing to a cardiac chamber or venous structures. Those are the courses that I think we already kind of discussed. And well, we didn't talk about the retroaortic. So the retroaortic is not considered to be a malignant and not considered to put the patient at risk for sudden cardiac death, like the interarterial. Okay, so surgical bypass or on-roofing has been recommended in these patients because of that increased risk. And of course, all the benign variations, nothing to do about those. And there is a correlation with other cardiac abnormalities, like the tetralogy of Fallot. So they can be incidental findings, and that is the case in a vast majority of cases. CTA is perfect. There's no better modality for this. Cardiac MRA in young patients when you want to avoid radiation exposure has been indicated, especially in cases where the anomaly that it is considered is out of origin, because those are the segments of the vessel that are better seen on MRA. When you start getting into the smaller, more distal segments or branches, then it's more difficult to visualize. All right, another great case. Any comments? All right, good. So let's keep going. Again, some really nice cases, and then we can save some of Dr. Limanovich for her to present next time, and then we can look at some other cases. And if any of you have any cases prepared, that'd be great as well. Actually, this is a good time to ask us. Any of you have any cases you want to share with the group so that I can plan accordingly our time?
Hi, this is Karen. I wanted to share a case, but I don't know how to hide the patient information out of Osiris. Is that a simple click?
On Osiris, I believe you use the tab key. You want to try it out?
Yeah, but I still was not able to hide.
All right, so
I'll keep trying and someone else can go. I have one case to share.
I'm pretty sure it's tab. Let's see. You can Google it as well, hiding patient info on Osiris while I show this case. But I'm pretty sure it's the tab key. Once you're in the opened images, not out in the browser, but in the opened images. All right, well, we do that. Case 4, 37-year-old man with a typical chest pain and a family history of sudden cardiac death. So this, oh wow, this is like nice case. Anybody wants to describe what we see here? So the history is pretty good for CTA, right? It's a young man. So just by age, likelihood is on the lower side of the spectrum. The chest pain seems to be atypical, so that would also suggest that that is probably low likelihood, and then does have a family history. So I guess part of the rationale here is looking for coronary anomalies, right? Those patients with atypical chest pain, and that risk of sudden cardiac death based on family history. However, we have here two curved reformats of the left coronary artery, and what kind of jumps at me here is this soft plaque here in the proximal segment, or actually it may be the mid segment because we already see a diagonal here of the LAD. If this patient would have had a calcium score, at least based on these images, we would have given him a score of 0. Nothing would have shown up there, but he did have some contrast on board to this, an angiogram, and we see this plaque here with at least 50% narrowing of the lumen on these orthogonal views. Proximal mid-coronary non-calcified plaque and with focal narrowing. Okay, so we got it right. So multiple choice question with 6 answers. So mild stenosis due to plaque, moderate stenosis due to plaque, pseudostenosis due to crossing coronary vein, pseudostenosis due to myocardial breach, severe stenosis due to plaque, and stenosis due to coronary artery dissection. Anybody wants to pick one of these? These are all good choices, I guess, for us to think.
Probably moderate. Maybe moderate stenosis due to atherosclerotic plaque, number 2.
I like that. Anybody else? Anybody wants to argue with us?
Oh, I think I might have called it mild.
All right.
It's on the borderline.
Tomato, mild, moderate, who cares? No, right? So before I jump onto the so I would probably call it maybe 50% narrowing. So right there, right borderline between mild to moderate. So both answers would probably pass as appropriate. So let's see. So, we're going to start with all the differentials. Okay, so this is a non-calcified distal plaque, proximal LAD plaque, less than 50% stenosis. So in much less significance than what we saw in our case. Moderate stenosis, I would say this is probably a little bit closer to what we're seeing. Again, this is a different patient. This is some calcified plaque on top as well, but here you hear think this is probably the best example of something that looks similar to what we saw, maybe even here too, which is probably the same or close. No, it's a different vessel, but this is the LAD, this is the right coronary. Severe, so yeah, clearly much more severe here. Just a trickle of blood flow going through there. And this is probably in that patient, showing us before and after intervention. So what's a pseudostenosis? So actually this is something that we see relatively often on coronary CTA. The coronary veins cross right on top of the proximal LAD. They create this triangle. Actually, this triangle has a name to it. I'm trying to remember. I believe it's the triangle of Koch, if I don't remember incorrectly. KOCH. Don't trust me. You can always Google that. But it's named after somebody, and it is relevant anatomy for the electrophysiologists. But anyway, when we have the vein crossing and there's an opacified, which is not the case of this MIP, it can put an imprint on the coronary, and it can definitely create what looks like a pseudo plaque, non-calcified plaque on those images.
Can I add something? So I think the triangle of Koch is related to the position of the AV node when you open the right atrium, and you kind of try to look at the interatrial septum.
Correct.
So I'm not sure if both triangles have the same name, but this is what I know about triangle.
It's that area, and why it's relevant to the discussion is because that's also when the SA nodal coronary branch, the small artery that feeds the node, originates from the left main or circumflex, which it's about 50-50 right to left side at the origin. They have to be careful in that area not to cut off that small branch, and that's a relation that it has to electrophysiology that you're alluding to.
Thank you so much.
All right, but again, don't trust me. Double check everything I say. All right, this another type differential, and this is a 38-year-old woman again. So number one, this is a female, which is where we see the sudden coronary artery dissections more commonly. They're much more common than in men. And this is a patient just delivered a baby 2 weeks ago. It's one of the risk factors, so one of the major physiologic stressors that the human body can go through and predisposes to SCAD or sudden coronary artery dissection. And you see here narrowing of the proximal LAD, a little bit of this haziness and thickening of the coronary wall that can be seen in SCAD. Like here, what looks like a bit of thickening and haziness of that wall that is described in sudden coronary artery dissection. Here on the luminogram, we just see a narrowing. We don't get the benefit of the wall thickening. So the diagnosis was moderate stenosis due to atherosclerotic plaque. Very good for that one. So coronary CTA, this is a great case for coronary CTA, like we mentioned before. It's used in the initial evaluation of patients with chest pain and low to intermediate probability. That's probably the gold standard nowadays in the institutions that have the expertise to do CTA. Also useful in the setting of an equivocal stress test to help determine with better accuracy what's going on with those patients. Again, the negative predictive value is superb. I would say it's closer to 99% than what this slide proposes. And again, so that's why it's so valuable in those patients with low moderate probability, because if we tell the doctor that the coronaries are clean, we really mean it. Chances are those are clean. We use transverse images, curved MPRs, and orthogonal views, and to look at those vessels in multiple reconstructions. So a couple teaching points we didn't talk about from the differential diagnosis list. Myocardial bridging. So That is when the coronary has an intramyocardial course. So there's fibers of the myocardium that are bridging over and around the coronary. It's relatively common to see them. They're incidental findings. They usually happen in the mid-LAD for sure. There is an association with hypertrophic cardiomyopathy on some of these variations. For the most part, these are thought to be benign, but when you have patients with intractable chest pain, we don't have an etiology for the chest pain, and this is the only thing that we find. They can certainly be assessed to see the depth of the coronary, the length of the segment. Sometimes it's just a partial bridge and not the entire coronary, only the undersurface of the coronary is bridged. So when it is a complete bridging, sometimes the surgeons decide that there is no other reason for the patient to have this chest pain that looks coronary in origin, and they go in and they just kind of cut those few fibers across the coronary to let it reach out and become epicardial again. And that has been described as successful in that small subgroup of patients. All right, case 5. Dr. Ardovas, you ready?
Yeah, I can show it. If you don't mind my dog barking in the back. So this actually, it's a really interesting and recent case that I wanted to get your opinions on it.
All right. So you should be sharing as soon as you accept to share.
Okay, just a sec. Accept to share. Share my webcam. Nope.
Not your webcam. We don't need to see you. Just.
I'm glad you don't.
Just share your screen. Are you there?
Sorry, I'm having several technical.
You still have.
There's something that says waited to be your DVD screen.
You want me to share again so you get the prompt again?
Yeah.
All right, let me see. All right, I need to find your name here now and make you presenter.
Okay, it's just not working. I guess you should just continue, and I'll prepare next time. I'll show you guys this case.
All right, so let's see. We have about 15 minutes or so. So let me just show you a couple of cases. We'll leave some of those from the presentation for next time for Dr. Limanovic. I'll show you directly from Osiris if it works. Okay. All right. So let's start with a chest X-ray. That's a scout, but we do have the chest X-ray here, and it's a little bit. All right. So I would take comments from the group. So let me just. Of course, I'm showing you just a part that I'm already zooming in, and then I'm gonna work on the. Whoa, too much. Okay, I'm gonna narrow my windows, and so we have this little wisp of a structure here. Any comments on that? This was actually prospectively picked up on the chest X-ray, not by me, by someone much smarter than me.
I mean,
looks like a valve of some kind. But
It looks like a valve. Yeah, that's correct. So, it's pretty central in the heart, which usually kind of I think of the aortic valve being always in the center of the heart, and every structure kind of follows around that in normal anatomy most of the time. However, if you see the direction of the valve and the attachment sites of the valve leaflets here, it seems to be inclined in the opposite direction that you normally see the aortic valve, right? The aortic valve is usually pointing the orifice towards the right shoulder of the patient. So top left of the screen, which is the right shoulder of the patient, correct? And this one seems to be almost pointing towards the top left, of the left shoulder of the patient, or the top right of the screen. And that was kind of mentioned on the chest X-ray. So the patient went on to have a CT. So there's a sternotomy wires, right? Because we know the patient had surgery. We know that much. A few lymph nodes here and there. The surgery was probably not too long ago. There's a little bit of stranding still around the surgical bed and the anterior mediastinum. Some plaque, and again, this is not a gated study, so we're not going to say much about that, just that it's there. But then we see this valve seems to be a little bit off plane and off the annulus of the aorta. It's going to be better seen here in these coronal views. And you can tell right there, just to make things a little bit more educational, I guess, the plane of the aorta is like this, and the plane of that valve seems to be kind of like this. So completely off plane. So that valve is coming off position. It's adhescent, the aortic valve. The attachments are the sutures of the valve are not holding it in place. And that was a very good pickup on that chest tape by whoever read it a little while ago. This is not a brand new case, but it's not too old. I have a companion case. I didn't have a chance to get the DICOMs, but I had already selected some images from the echo. So this is a different patient. This 68-year-old lady went in for an echo. Some symptoms suggestive of some degree of heart failure. Anybody wants to comment on this? Here you go. You put some Doppler in it. All right. So there seems to be some regurgitant colors adjacent to the edge of the mitral valve prosthesis. You see all the streak, or I should say the echo by the mitral valve. So this patient, they questioned this. There was murmur, so patient came to get a CT done afterwards. And again, I'm not showing the DICOMs, but I selected some images already. So this oblique sagittal view, almost like a candy cane of the aorta, and you can see here the streak from the metal from that mitral valve. And what really caught everybody's attention was discontinuity of contrast below the ring of the mitral leaflet. So I guess the mitral valve does not seem to approach the edge of the anatomical ring. This is an oblique two-chamber view / coronal view. Again, you have the mitral in place. The angulation is not as off as in that aortic valve, but you can see again there's discontinuity of where this should be sutured in, and that continuity of contrast between the left ventricular cavity and the left atrial cavity. And just on your plain axial images, some infiltrates at the left base, maybe aspiration. But you can see here, we're right below, right at the bottom, just above this the coronary sinus. So this is just the edge, the lower anterior-most left atrium, and you can see that continuity, that communication between the left atrium and the left ventricle outside of the valve orifice. So another case of a valve dehiscence now in the mitral valve, not in the aortic position. So very quickly, just prosthetic dehiscency has been well described in the literature. This is a result of sutures pulling out the tissue. Lots of reasons for this. It can be a patient that had an infection in the area, so the tissue is friable. The technique was inadequate, was not taking enough tissue, or just a diseased cardiac tissue prior infarct, for example, or in that area, or a pseudoaneurysm or an aneurysm near the sinus of Valsalva for aorta, for example. Any issue with the cardiac tissue may make these patients prone to dehiscence. And again, depending on how extensive, you can have significant regurgitation at that location. Can be for minimal paravalvular leak, which may go unnoticed clinically for a while, to just abnormal motion and or rocking of the whole prosthesis, which can become quite severe and quite an issue physiologically. The incidences in the literature are pretty wide. They go from 18 to almost 50% in both mitral and aortic positions. Again, the vast majority are going to be trivial and nothing is going to be done about them. I'm talking about, of course, I talk about paravalvular leaks, but this is all in the context of surgical repair, not TAVR or TAVI. Again, patient that had surgery late after mitral insufficiency or aortic insufficiency late after surgery, so it's a late development of a new onset severe insufficiency. That's usually resulting from an underlying issue such as endocarditis, or the mechanisms of the valve proper are the ones that are failing. The leaflet stays locked in open position, etc. Again, the incidence varies quite a bit from type of valve and also the position. Something to keep in mind in these patients, even if the insufficiency is trivial, is that they may undergo hemolysis, and at some point, depending on the patient and the other comorbidities, it may become a clinical issue for them, but there may be hemolysis and chronic hemolysis in these patients. This usually happens in the mitral position. All right, so I think we have time for one more case. Well, before we finish to that, I want to remind everyone, we are planning to see all of you in September for the NASCI annual meeting in Cleveland, Ohio. That in the background, that's the Rock and Roll Hall of Fame. We're going to have our gala dinner there. That place is spectacular. It's going to be a lot of fun. We're going to have a live concert there. So we all expect and hope that we're going to be done with the current pandemic, and we'll be able to see all of you in September in Cleveland. It's going to be a fantastic meeting. All right, one more case. I think we have one more case somewhere here. I had a chest x-ray. I don't see it, so we're gonna, well, we can use this. We can use the Scout. That'll do for today. All right, any comments, guys, on this Scout? So there's a
big right atrium.
I'm sorry?
Big right atrium. Is the big right atrium?
Yeah, there's a big heart, and clearly the right contour is very, very prominent. So that's very suggestive of right atrial enlargement. And we have a dual chamber pacer device here. So leads in the right atrial appendage potentially, or that's what we hope, and the right towards the right ventricular apex. And again, markedly enlarged right cardiac contours. Let's just look at the images with contrast. So a lot of contrast here in the atrium, so we don't see the leads there. Right atrial appendage lead. We start seeing that the hearts, yes, both atria look big, but really everything starts to look big. There's an effusion as well, also in the left contour, and then we see the right ventricular lead there in place. What's really interesting in this case is probably right here this image where we see this lead. It's very close to the septum. It's very parallel to the septum, and I'm gonna try and convince you, but you can see the tricuspid valve here, the leaflets in place. They're not completely open. They seem pretty horizontal. They may be somewhat closed at the time of imaging. Again, this is not a gated exam. But you can see, I believe, this lead perforating the septal leaflet of the tricuspid valve. You see what I think is a little bit of hypoattenuating linear structure here medial to that lead. So we're suggesting that I'm suggesting to you guys that there is damage to that tricuspid valve leaflet by the right ventricular lead on this permanent pacer device. And that clearly creates an inability of the valve to move properly and can create, and that has been described in the literature, creates significant regurgitation, which may explain the cardiomegaly that's predominant on the right atrium. And so looking at the literature, there's this nice series from Mayo Clinic. This is from their echocardiography lab. And I went through this and I highlighted a few lines that I thought were worth bringing up to discussion with this case. This is just patients that were already identified with severe tricuspid regurg. So this is not a group of patients trying to determine how often this happens, but this is patients with known severe tricuspid regurg. So they took those 41 patients, went back, looked at the echo reports, the echo images, and then these patients went for surgical repair. So they looked at the surgical reports as well. And if you look here, I'm just going to move this screens a little bit here. So the findings on these 41 patients, there was lead adherence to the tricuspid valve in 14 of them. There was lead impingement in 16 of them, but there was also perforation in 7 out of the 40. So, close to 20%, just under 20% of those patients had perforation of the tricuspid leaflet. So here in the discussion, they talk about autopsy reports. So this has been seen in autopsy reports that the permanent pacemaker leads can cause fibrosis and adherence as early as 17 days after implantation. So that's just over 2 weeks after implantation, they can start creating some damage to that tricuspid valve. And if you think about it, just by even if there's no adherence, just by putting a lead through that orifice, you're pretty much not allowing the leaflets to coapt appropriately. So you should always have at least a trivial amount of tricuspid insufficiency moving forward. So the direct visualization of the mechanism of the pacemaker or ICD lead causing severe regurg was only identified in 12% of those 41 patients, so 5 of those patients in the routine TTE. So the authors went back, looked for those that had a transesophageal as well, and on the transthoracic, they went back now knowing what they now know, and they say that retrospectively they could see it in up to 22%. So even knowing that it was there, it's really hard to visualize on echo. So they here suggest transesophageal echo of another opportunity. I think probably CT or even MRI is when appropriate. The problem with the MRI is all the Ricard effect, susceptibility effect from the lead, but at least on CT, you should be able to suggest this. So again, the authors have seen an increased number of tricuspid valve operations to correct severe regurgitation related to pacemaker devices, and it's injury related to their leads, at least performed here. Again, in a vacuum, don't know what to make of this. They're probably just doing more surgeries and putting more paces in general as new and better devices come online. But at least the absolute numbers have increased according to this paper. So with that, it's 5 o'clock. So wow, we took the entire hour. Any comments, any questions?
Great cases. Thank you so much.
No, thank you guys for joining us. Hope to see you here next month. Please stay safe, protect yourselves and your family, and be well. And just, thank you for being a part of NASCI.